the anticipated papal encyclical entitled Humanae Vitae. Dr. Matthias Thacker was one of the many Catholic parishioners who read it with disappointment bordering on disgust. A husband and wife must understand that their mission of responsible parenthood, Pope Paul VI declares in the text, but they must conform their activity to the creative intention of God, expressed in the very nature of marriage and in other acts, and manifested by the constant teaching of the Church. The creative intention of God, the Pope had discerned, permitted rhythm but not the birth control pill. There are essential differences between the two cases, the encyclical declared. In the former, the married couple makes a legitimate use of a natural disposition. In the latter, they impede the development of a natural process. There are some lengthy passages about the rhythm method giving proof to a truly and integrally honest love, while artificial contraception might cause the man to lose effect for the woman. And Thacker studied the encyclical from the beginning to end in his archdiocesan newspaper, looking for the logic that would convince him the book was right. He couldn't find it. That ship had sailed. That was how Thacker would think of it. All this labored reasoning of Humanae Vitae was not going to call it back. There were Catholic women all over the world taking birth control pills in the morning before they went to Mass. In his office, when his married patients asked for them, Thacker went on writing prescriptions for birth control pills. Maybe he was a bad Catholic. Clearly he was ignoring the explicit instructions of the magisterium, the official interpreters of Roman Catholic doctrine. In the confessional, Thacker generally found a variety of moral failings to unload from his conscience, but helping dispense birth control pills was not one of them. Perhaps it was rationalism. Perhaps the conscience was more elastic than it should have been. But when he looked at what he was doing, he could find no genuine sin to confess. It was none of his business, that was all. His patients could follow the magisterium or not follow the magisterium. They could go making their own confessions. If their consciences were troubling them, he was not going to lecture them about artificial contraception. He was not going to debate artificial contraception on a public stage. He was certainly not going to drive to the capital city of his home state and demand that his church's directives on artificial contraception to be incorporated in the state's books. The statutory books were for everybody, Catholics and non-Catholics alike. And if you don't spend 2 hours negotiating the highways to Jefferson City, or lose your Thursday evening in the Craigmore Township Republican organization, unless everyone was enthralled, unless men in charge of the statute books were tampering with an idea as basic as human life.
Hi, my name is Megan Gleason, and I'm from Springfield, Missouri. And I will be reading The Impact of State Mandatory Counseling and Waiting Period Laws on Abortion, a Literature Review. Highlights. As of January 2009, 24 states require that women must receive counseling with certain state-specified information and then wait, usually for 24 hours, before an abortion can be performed. A literature search identified 12 studies of the impact of mandatory counseling and waiting period laws. The clearest documented impact was obtained from analyses of Mississippi's mandatory counseling and waiting period law, which requires an additional in-person visit before the procedure. Following enforcement of the law, abortion rates fell. The number of women going out of state for an abortion rose, and the proportion of second trimester abortions increased. Waiting period laws that allow mandatory counseling to be delivered over the internet or by mail or telephone appear to impose relatively little cost on patients, and neither the waiting period requirement nor the mandatory counseling has a measurable impact on reproductive outcomes, other than to postpone the timing of some abortions. Some studies found large impacts of these laws on infant and child health, as well as on suicide rates. However, these findings are implausible given the small or undocumented increase in unintended childbearing associated with the laws and the limited data on infant and child well-being. Many studies of mandatory counseling and waiting period statuses have limitations, including incomplete data and inadequate controls for factors other than the imposition of the law. Future research should aim for straightforward designs. Researchers should strive for transparency by showing pre-law trends and outcomes among those who were exposed and unexposed to the law. They also should clearly discuss expected outcomes, statistical power, and the plausibility of their findings. Background. Many states require a waiting period between the time a woman has been counseled about her abortion and the actual procedure. As of January 2009, 21 states required a mandatory waiting period of 24 hours. One state required a waiting period of 18 hours and another period of 1 hour. One state required that counseling take place on a day prior to the abortion, but did not specify the length of the waiting period. 4 other states had mandatory counseling and waiting period laws whose enforcement had been enjoined, i.e., that were legally prohibited from taking effect. These laws specify that certain information must be given or offered to the woman at the initial visit. The required counseling usually includes, among other things, the gestational age of the fetus, information about fetal development, the risks of abortion and childbirth, and resources available for pregnant, low-income women. Some mandatory counseling and waiting period laws stipulate or have been interpreted to mean that a woman can be counseled via mail or phone about her procedures. Others require that the woman be counseled in person, which usually means she must visit the facility twice, once for counseling and again for the procedure. Moreover, the content and the complexity of mandatory counseling laws have changed over time and may continue to evolve. For example, beginning in 1996, providers in some states have been required to give women information about the option to view an ultrasound as part of the verbal or written materials given during the mandated counseling session. Proponents of mandatory counseling and waiting period laws argue that the state has a duty to ensure that before a woman decides to terminate a pregnancy, she has been given ample time, after having been given information about her pregnancy and abortion, to weigh her options. Those opposed to these laws argue that such statutes are unneeded because physicians are required to obtain informed consent before all procedures, including abortion, that the laws impose an unnecessary burden on women who are seeking abortions, and that women are able to make informed decisions about terminating the pregnancy without the imposition of a state-mandated waiting period. Opponents further agree that mandatory counseling and waiting period laws serve no medical purpose and are a ruse to decrease the accessibility of abortion. Because no other common medical procedure has a largely mandated wait period of this kind, the potential impacts of these waiting periods are unique to abortion provision. Mandatory counseling and waiting period laws are relatively new and were declared constitutional by the Supreme Court in 1992 in the landmark case Planned Parenthood of Southeastern Pennsylvania versus KC. What impacts do mandatory counseling and waiting periods have on the financial and emotional states of women seeking abortions? Do they force women to have abortions at a later stage in pregnancy or block access to abortion services? Does mandatory counseling dissuade women from having an abortion? Are women traveling out of their home state for abortions when counseling and waiting period laws are enforced in their state of residence? Furthermore, what impacts do these laws have on abortion providers? Efforts to address these questions have proven difficult. Evaluators of mandatory counseling and waiting period laws face many of the same challenges that confront researchers of other state policies that affect access to abortion services, such as parental involvement laws and Medicaid financing of abortions. For instance, national data on abortion compiled by the Centers for Disease Control and Prevention are collected by state of occurrence and not by state of residence. Using abortion data by state of occurrence to evaluate a mandatory counseling and waiting period law can lead to spurious findings of women if women leave their state of residence for an abortion, and if non-residents stop coming into a state for the procedure once the law is enforced. The problem is exacerbated by the relatively few states, 7, that enforce the strictest form of the mandatory waiting period law, requiring in-person counseling at least 18 hours prior to the procedure, since women can travel to nearby states if they want an abortion without a required delay. In addition, mandatory counseling and waiting period laws affect women of all ages and incomes, not just minors or those eligible for Medicaid. However, older, non-poor women have more education and are more likely to have independent income, their own means of transportation, and other resources that could make accessing services in other states a more feasible option. For the results of an evaluation to be valid, therefore, research should demonstrate that few women left their states of residence to obtain an abortion in response to laws of this kind, or if they did, the researcher must be able to include in an analysis abortions obtained by a state's resident in other states. There are, however, important differences between mandatory counseling and waiting period laws and parental involvement laws that should be considered by analysts. First, some states require that counseling be given in person by the physician who will perform the procedure or by a designated staff person. Other states allow the material to be read over the phone or delivered via a recorded message, by mail, or more recently over the internet. The in-person requirement is a potentially important decision, for it increases the cost of an abortion if a woman has to take off from work, arrange childcare, or stay overnight when the distance to the clinic is too great. Thus, it is important for researchers to analyze states that have an in-person requirement separately from those that do not. The two-visit requirement increases not only the cost of the abortion, but also the likelihood that a woman will travel to a nearby state to avoid compliance with the law. The issue is further complicated because some abortion clinics may provide a way for women to receive face-to-face counseling from a physician near their homes, thus avoiding a trip to the clinic. It is difficult for researchers to determine the extent of these arrangements. Another difference between parental involvement laws and mandatory counseling and waiting period laws is that all women in the state are subject to the latter. This makes it difficult to find a comparison group within the state. Parental involvement laws, by contrast, affect only minors, which leaves older teens within the same state as a plausible comparison group. The advantage of a within-state comparison group is that those exposed or unexposed to the law are all subject to the same political, social, cultural, and economic conditions. Comparisons across states require careful analysis, since large differences in states' abortion rates may reflect profound differences not only in attitudes towards abortion, but also in pre-law trends in abortion, birth, and pregnancy rates. Finally, the most likely effect of mandatory counseling and waiting period laws is on the timing of an abortion. Numerous studies have evaluated whether such laws are associated with an increase in second trimester abortions or in mean gestational age. These analyses require information on gestational age, which is available only from the Centers for Disease Control and Prevention and state health departments. The other major source of abortion data, the Guttmacher Institute, estimates abortions by state of residence and a woman's age, but not by gestational age. Thus, abortion data from the Guttmacher Institute cannot be used to analyze the effect of these laws on the timing of abortion. The research designs used to evaluate mandatory counseling and waiting period laws are very similar to those used in studies of parental involvement statutes. The most effective designs use a pre-post analysis with a comparison group and are referred to as differences estimators. The change in the abortion rate or in the rate of second trimester abortions from before to after the law went into effect in a state, the experimental state, is compared to changes in rates in states without such statutes, the comparison states. Such comparisons attempt to ensure that any variation in the abortion rate associated with the law is not compounded by ongoing trends in the abortion rate that reflect broader unrelated changes. As straightforward as this design appears, it rests on the credibility of the comparison group. Both the pre-law trend and the abortion rate, as well as the characteristics of the women themselves in experimental and comparison states, should be as similar as possible. Differences in the rate or trend would suggest potential confounding factors. However, few studies present plots of trends in the outcomes in the experimental and comparison states. Instead, researchers typically rely on regression analysis to control for observable differences between states. Yet common factors used as controls, such as race, per capita income, and even the number of abortions provided, tend to change relatively slowly over time. These factors may be correlated with differences in the abortion rate between states, but they often have little ability to explain changes over short periods of time. A common regression technique is to include a dichotomous indicator for each state in the sample. Because there are 50 states, the researcher would include 49 dummy variables. This set of state indicators is referred to as state fixed effects, and their inclusion removes any variation between states in the abortion rate and the included covariance that is fixed over time. For example, if the difference in abortion rates between California and Utah partly reflects long-standing differences in religiosity, then the state fixed effect will remove this source of between-state variation in the abortion rate. As a result, it can be concluded that the association between mandatory counseling and waiting period laws and the abortion rate is based solely on changes in the dependent and independent variables within each state. Similarly, the inclusion of year fixed effects variables, i.e. a dummy variable for each year, adjusts for variation over time in the dependent and independent variables that is common to all groups and states. State and year fixed effects models are now commonly used, particularly by economists, in evaluation of abortion laws. This approach is a powerful way to reduce confounding from hard to measure variables and allows researchers to use all 50 states to maximize the number of experiments. However, when doing so, researchers implicitly assume that variation in the abortion rates of states without counseling and waiting period laws, such as California, New York, and Illinois, is a good counterfactual for trends in states with such laws, such as Utah, South Carolina, and Mississippi. This is a dubious assumption, since state and year fixed effects do not control for differences in trends in abortion rate or other outcomes within states. Distinguishing short-term from long-term effects of a law is another challenge. A mandatory counseling and waiting period law may cause an initial drop in abortion rate or a rise in the rate of second trimester abortions. However, as more women become aware of the law, and as more clinics improve scheduling and administration of the counseling, the costs associated with compliance may fall, along with the law's impact on outcomes. In any case, it is very difficult to credibly link longer-term declines in abortion or the timing of abortion to the impact of the law, given the likelihood of confounding from other factors that influence abortion rates. In the end, the best research designs are the most transparent. Pre-law trends in the abortion rate or in the rate of second trimester abortions in experimental and comparison states are key factors to review. If mandatory counseling and waiting period laws have a substantial effect on abortion rates, then there should be an obvious discontinuity in the time series. Further researchers should consider plotting abortion rates for groups of states that change their laws in the same or nearly the same year and comparing them with plots of states with similar abortion rates but whose laws did not change. This approach would allow for the examination of differences in levels and trends of abortion rates between experimental and comparison states. If the natural experiment afforded by these laws is truly exogenous, i.e. the changes in laws are not associated with other state-level factors that may also affect the outcome of interest, and changes in the abortion rate among the comparison groups effectively capture ongoing trends, then estimated effects based on simple difference in difference estimators should not change when additional factors are added to the model. As in randomized designs, adjustment for other factors will be used in such models to improve the precision of the estimates and not to control for confounding. Methods. We identified published research on the impact of mandatory counseling and waiting period laws using 4 search engines: Google Scholar, PubMed, Popline, and Web of Science. We used the search terms abortion and mandatory delay, abortion and waiting periods, and abortion and required counseling, and searched for all articles published after 1900. We scanned the titles of the articles returned from the database searches and eliminated ones that were obviously not relevant. We then collected and reviewed abstracts of the remaining articles to identify those that were eligible for inclusion in the review. To be eligible, articles had to be published in English and focused on the United States, and had to present original research and provide details on the impact of mandatory counseling and waiting period laws on reproductive behavior or other outcomes. We examined the citations in the articles selected to identify additional papers to consider for inclusion. We also consulted with experts in the field and gathered articles that received media attention during the time of our review, September 2007 to December 2008. Our initial search of PubMed, Popline, and Web of Science yielded 50 potentially eligible papers. 38 of these were excluded because they focus on historical overviews of mandatory counseling and waiting period legislation, or rights-based discussions of the theory of mandatory counseling and waiting periods, or were reviews of legal cases regarding the issue. A search using Google Scholar returned 3,610 hits. Many of these were repeats or were not selected for the reasons cited above, or because they did not discuss these laws in relation to abortion. One additional study from Google Scholar was included in this literature review, and 2 additional studies were contributed by experts. We thus reviewed 15 articles and eliminated 3 articles that were reviews of these laws, but that did not measure their impact, leaving 12 studies for inclusion in our review. All 12 studies evaluated waiting period laws. No studies were found that focused specifically on counseling laws, though one study evaluated waiting period and counseling laws separately. A summary of these articles is presented in Table 1. In addition to describing the data, methods, and results, we include an evaluation based on our judgment of the quality of the overall approach and the credibility of the findings. Studies of reproductive outcomes. Researchers have examined the impact of mandatory counseling and waiting period laws on a number of reproductive outcomes: abortion rates and ratios, birth rates, the proportion of abortions among state residents performed out of state, and the gestational age of fetuses at abortion. We examine researchers' findings in the context of their work and provide detailed information on the full requirements of the law in the state of interest for each study that focuses on individual states. The specific requirements of these states' laws are constantly reinvented or reinterpreted. It is important to note that many changes in the laws may have occurred since these articles were published. Reproductive outcomes among women of childbearing age. 6 studies evaluated changes in abortion rates and ratios following the implementation of mandatory counseling and waiting period laws. 1 study also assessed the impact on birth rates. 4 studies analyzed changes in the timing of abortion, and 3 examined the impact of laws on changes in where abortions occurred. 4 of the 6 studies found a statistically significant association between mandatory counseling and waiting period laws and abortion rates. 3 of these studies focused on Mississippi. The studies are presented chronologically. 2 studies, which are presented last, found no impact of these laws on reproductive health outcomes. Alvis and Henshaw examined detailed abortion data from the Mississippi State Department of Health's Division of Public Health Statistics to determine the effect of the state's 1992 mandatory counseling and waiting period law on abortion trends. The researchers used state-collected information on residents who had abortions in Alabama and Tennessee to examine the effect of the law on women traveling out of state. The bordering state of Louisiana does not collect abortion data on out-of-state residents, and the authors did not gather data from Arkansas. Typical of other mandatory counseling and waiting period laws, Mississippi statute required that a woman be given information at least 24 hours prior to the abortion regarding the name of the physician who would perform the procedure, the medical risks associated with abortion, the probable gestational age of her pregnancy, and the medical risk of continuing her pregnancy. In addition, a woman was required to be informed about medical assistance benefits available to her if she continued the pregnancy, the father's liability for child support, the availability of pregnancy prevention services, her right to review state-produced materials that listed services to assist a woman through pregnancy and childbirth, and a brochure that described fetal development. All of this information had to be delivered by the referring physician or the physician performing the abortion. In Mississippi, the law requires a woman to hear the information in person, which clinics have interpreted as face-to-face. This necessitates 2 in-person visits to the clinic. In a before and after analysis of state-level abortions, the researchers found that the actual number of abortions performed in Mississippi was 22% lower than expected based on previous years. They also found that the number of abortions provided to non-residents fell 30%, while the number of Mississippi residents who obtained an abortion in Tennessee or Alabama increased by 17%. Overall, the researchers concluded that among women who would have had abortions, the law prevented approximately 11 to 13% of them from obtaining one. The law was also associated with women having abortions later in pregnancy. The proportion of Mississippi women who obtained an abortion after more than 12 weeks of gestation increased by 17% in the 5-month period after the law was enforced, compared with the 7-month period prior to enforcement. In addition, the decline in abortions was greater for women with less than 12 years of education than for more educated women. This was the first study to use data on abortions to evaluate the impact of mandatory counseling and waiting period laws. A strength of the study is its use of abortion data by state of residence. The data show that not only did women leave the state to obtain an abortion, but fewer women came into the state for an abortion. The major limitation of the study is the lack of a control group other than Mississippi and the months before the law took effect. Although the number of abortions fell sharply in the months right after the law's enforcement, abortions might have fallen somewhat in the absence of the law. Thus, we don't doubt that the waiting period requirement had a statistically significant effect on the number of abortions in Mississippi, but the exact size of the decline is uncertain because of trends in abortion that may have existed prior to the law. Joyce, Henshaw, and Scatrude extended the work of Althus and Henshaw by analyzing the effect of Mississippi's mandatory counseling and waiting period statute on abortion rates and birth rates, as well on the timing and location of abortions for the period of 1989 to 1994. They used Georgia and South Carolina as comparison states, since neither state enforced a mandatory waiting period during these years. This enabled the researchers to use a difference in differences methodology. The authors also estimated a regression model using monthly abortion rates in these 3 states over this period. The authors reported that the abortion rate in Mississippi dropped by 16% in the year following enforcement of the mandatory counseling and waiting period law. In the same period, the abortion rate fell by 5% in South Carolina and 3% in Georgia. Thus, they estimated that Mississippi's law was associated with a 12 to 14% decline in the abortion rate among residents. The authors concluded that they likely overestimated the decline since they lacked data on Mississippi residents who obtained abortions in Louisiana. To adjust for this, they estimated the likely number of abortions that residents obtained in Louisiana based on that state's 1988 data. After adjustments, they concluded that Mississippi's mandatory counseling and waiting period law was associated with approximately a 10% decline in the resident abortion rate. The authors also found that the number of abortions obtained out of state rose in absolute and relative terms, as did the number of abortions performed after 12 weeks of gestation. The authors reached no conclusion regarding the impact of the law on birth rates because of a lack of statistical power. This study underscores the strengths and limitations of individual state analyses. First, the author's ability to measure changes in where abortions occurred was critical. Without resident abortion rates, there would be no way to accurately assess the impact of the law on the incidence of abortion. The quality of the resident abortion data appears to be good, as comparisons with data obtained by the Guttmacher Institute's independent survey of abortion providers indicate that Alabama, Tennessee, and Mississippi have relatively complete abortion reporting. Thus, the authors were able to assess the extent to which women left Mississippi to obtain abortions in these other 2 states, which turned out to be substantial. The proportion of abortions obtained by Mississippi residents outside the state increased by 42%. Another strength of the study is the selective use of comparison states. Georgia and South Carolina are demographically and politically similar to Mississippi. Indeed, both of these states went on to enforce mandatory counseling and waiting period laws. Finally, the authors presented the data in a transparent manner. They showed trends in abortion rates and birth rates in Mississippi and the 2 comparison states, both before and after the law. The regression results simply confirmed statistically what was apparent from the time series plots. However, the authors did not adjust for serial correlation of the residuals and likely underestimated standard errors on the regression coefficient that measured the impact of the law. In addition, as in all case studies, the magnitude of the effect may be different in other states. Mississippi is a poor, rural state that has one of the lowest numbers of abortion providers per capita in the country. I passed the microphone.
Hi, my name is Sophie and I'm from Springfield, Missouri, and I'm here filibustering tonight because I believe all women should be able to make their own decisions about their health care. Furthermore, Mississippi's law is stricter than those in most states, since it is interpreted to mean that the pre-abortion counselling must be conducted in person. Other states that mandate counselling and a 24-hour delay permit information to be delivered over the phone, by mail, and over the internet. The authors argued that their results were unlikely to be generalizable to states that did not have an in-person requirement, which effectively requires at least 2 visits to the clinic. Despite these limitations, the work by both Alphos and Henshaw and Joyce, Henshaw, and Scatcherd underscores the need to interpret results cautiously from studies that evaluate mandatory delay laws using abortions measured by states of occurrence. Joyce and Keatsner returned to Mississippi to evaluate in more detail the effect of that state's mandatory counselling and waiting period law on the timing of abortion. Again, the appeal of Mississippi as a case study in the strictness of the law, a 2-visit in-person requirement, and the quality of the resident abortion data. The study was unique because the authors created a within-state comparison group of women who live closer to abortion providers in Tennessee. They hypothesized. They found that the proportion of second trimester abortions rose by 45%, and the mean gestational age at abortion increased by 4 days among women whose closest provider was in state compared with women whose closest provider was out of state. These results were consistent with those of Alphas and Henshaw and Joyce, Henshaw, and Scatcherd, which should not be surprising since all 3 studies focused on Mississippi. However, each study used a different counterfactual or comparison group, which makes the consistency more compelling. Nevertheless, these 3 studies pertain to one state and one specific type of law, and thus their generalizability should be viewed with caution. Using data from the Centers for Disease Control and Prevention on Abortions by state of occurrence, Bitler and Zavodny conducted a pooled time series analysis for 29 to 40 states for the period 1974 to 1997. Not all 40 states reported abortions by gestational age each year. Their goal was to assess how policies that restrict access to abortion services affect the timing of abortions and the abortion rate among women aged 15 to 44. One policy they analysed was mandatory counselling and waiting period laws. They used regression analysis to control for demographic characteristics and state economic conditions. They also included proxies for the political climate, as well as state and year-fixed effects. By 1997, 11 states had begun enforcing mandatory counselling and waiting period statutes. But these state year observations accounted for only 3% of the overall sample. In models without state-specific trend terms, these laws were associated with a 2.3 percentage point increase in the proportion of abortions occurring in the second trimester, and with a 41% increase in the rate of second trimester abortions. Laws had no statistically significant effect on the overall abortion rate. A strength of the study is the analysis of both the proportion and the rate of second trimester abortions. It is possible for the proportion to rise but the rate to remain unchanged or even fall following implementation of a mandatory counselling and waiting period law if the overall abortion rate declines because of a decrease in first trimester abortions. The results regarding the association between the timing of abortion and the state's law appear to be in approximate agreement with those of Alphaus and Henshaw and Joyce, Henshaw and Scatcherd. However, Mississippi's law was associated with a significant decrease in the abortion rate, whereas Bitler and Zavodny found no such association. This is an important difference since the decline in the abortion rate in Mississippi associated with the law would have been much larger if the studies of Alphaus and Henshaw and Joyce, Henshaw and Scatcherd had measured abortions by state of occurrence. Many residents of Mississippi left the state for an abortion in the year immediately after the law was implemented, and fewer non-residents came into the state to obtain an abortion. In other words, by analysing abortions by state of occurrence, Bitler and Zavodny's study was biased toward finding a decline in the abortion rate. Since by 1997, only Louisiana, Mississippi, Pennsylvania, and Utah required 2 in-person visits. This study suggests that mandatory counselling and waiting period laws that do not require 2 clinic visits have little effect on abortion rates, but many may cause delay in terminating a pregnancy. However, the increase in the second trimester abortion rate was greater than could plausibly be caused by counselling and waiting period laws. Mayer et al. Used a pooled time series design and data from all 50 states for the period 1982 to 1992 to estimate the effect of a waiting period law and an informed consent statute, which did not necessarily mandate a waiting period, on the abortion rate of all women aged 15 to 44. These laws were among 23 policies related to abortion that were included simultaneously in the analysis. Results indicated that neither the waiting period nor the informed consent statute had an impact on the abortion rate. This study is unique in that the researchers did not account for state fixed effects, but instead included the previous year's abortion rate to control for hard-to-measure determinants on abortion. In theory, the lagged abortion rate was an effective way to control for these determinants between states. However, the coefficient on this rate was close to 1.0. In essence, the authors were trying to correlate one-year changes in the abortion rate with the level of the other covariates. A more appropriate approach would have been to regress changes in the abortion rate on changes in the covariates and policy variables. Any association using this approach could have been interpreted as the effect of a change in an abortion policy on the change in the abortion rate. Another problem with this study is that few states enforced waiting period laws before 1992, and many were waiting for the Supreme Court to decide Planned Parenthood of Southeastern Pennsylvania versus Casey before enforcing their laws. In sum, the finding that waiting period and informed consent laws had no effect on the state abortion rate could be due to the weak design of the study. Medoff analysed the determinants of the ratio of abortions to pregnancies using state-level data from the Guttemacher Institute for the years 1982, 1992, and 2000. He focused on 3 abortion policies: mandatory counselling and waiting periods, parental involvement laws, and the Medicaid financing of abortions. He considered the price of abortion, other socio-economic characteristics of the state time trend variables, opportunity costs, the policies of neighbouring states and proxies for state sentiment toward abortion, e.g. percentage of population affiliated with an evangelical Christian denomination, that have been found to be detriments of abortion demand. Mandatory counselling and waiting period laws had no statistically significant impact on abortion ratios among all women or among minors aged 15 to 17, or on whether abortions were performed out of state. This study is unique in that it explicitly included the price of an abortion in the abortion demand equation. However, including all mandatory counselling and waiting period laws with differing specifications might have masked the impact of the most restrictive laws. In addition, this was a weak design because the effect of the law was identified mainly by cross-sectional variation in a single year, 2000. Few states had such laws in 1992. The potential for confounding is great given that these laws are not randomly distributed but instead reflect political sentiment toward abortion. Reproductive outcomes among minors. Using individual level data, another Joyce and Ketzner study compared abortion measures among minors with those among older teenagers and young adult women living in Mississippi and South Carolina before and after the implementation of each state's mandatory counselling and waiting period law, which took effect in 1992 and 1995, respectively. One difference between the two laws was that in Mississippi, a woman was required to wait 24 hours before the procedure could be performed. But in South Carolina, a woman was required to wait only 1 hour. As a result, a termination in South Carolina could be completed in one visit. The researchers analysed data on abortions obtained by women in their state of residence and in border states. But information on the number of Mississippi residents who obtained abortions in Louisiana was unavailable, which could potentially affect the results. They then compared teenagers whose nearest provider was in-state with teenagers whose nearest provider was out of state. The researchers also conducted a multivariate analysis that evaluated the probability of a woman having a second trimester abortion, of having an abortion out of state, and of the mean gestational age at abortion. Controls for race, marital status, previous live births, previous induced abortions, and distance to the nearest provider were included in the model. The researchers found that the probability that a teenager in Mississippi went out of state for an abortion after implementation of the mandatory counselling and waiting period laws was 26 percentage points lower for those whose nearest abortion provider was in-state than for minors whose nearest provider was out of state. They also determined that mean gestational age at abortion increased by more than half a week for teenagers whose nearest abortion provider was out of state, and by almost a week for teenagers whose nearest abortion provider was in-state. The results for South Carolina were markedly different. That state's 1 hour waiting period statute had no effect on either the timing of abortion or the probability that a teenager went out of state for an abortion. They concluded that this lack of effect may have been due to the relatively minor inconvenience of a 1 hour waiting period. The results also suggested that counselling alone was not a significant deterrent to women seeking an abortion. The study is noteworthy because the researchers used teenagers whose nearest abortion provider was in another state as a comparison group for teenagers whose nearest provider was in-state. However, there were relatively few minors in the comparison group, which diminished the ability to detect statistically significant changes in abortion rates. In addition, recent statistical research suggests that the authors likely underestimated the standard errors in the multivariate analysis, and thus they statistically significantly findings should be interpreted with caution. Studies of other outcomes. Researchers have also examined the impact of mandatory counselling and waiting period laws on the cost of an abortion, a woman's emotional and physical experience in obtaining an abortion, providers' experiences regarding the laws, infant and child health outcomes, the financial cost for providers and female suicide rates, 2 studies examined the qualitative experiences of abortion providers and their patients. 3 studies evaluated the impact of mandatory counselling and waiting period laws on infant health outcomes, and 1 study investigated the relationship between such laws and suicide rates. Qualitative experiences of patients and providers. Lupfer and Silver interviewed more than 300 women at 3 clinics in Tennessee about their experiences obtaining abortions following the implementation of a mandatory counselling and waiting period law in 1979. The law required that a woman wait at least 2 days after being examined in person by her physician and being informed about the benefits and risks of pregnancy and abortion before having her abortion. Counsellors or research staff asked women questions about their perceptions of the benefits and costs of the law, either after completing the mandatory waiting period or before and after the period. Interviews took place from October 1979 through January 1980, starting just 1 month after the law was implemented. The researchers found that the cost of an abortion increased for the majority of women. 62% reported that the required second visit increased the cost because of lost wages and additional transportation and childcare expenses. The study found that the second visit elevated costs by 48% for low-income women and by 14% for women with higher income. Fees were often scaled accordingly to ability to pay, and the amount of the increase was associated with a woman's distance from the clinic and the number of hours she was employed per week. 77% of women were unable to name a benefit of the waiting period, and some women reported negative mental, physical, and social consequences. 29% experienced mental anguish. 24% incurred extra transportation costs. 19% experienced additional nausea and they attributed to the delay. 15% missed time at work, and another 15% had to make excuses to explain their absence. 8% said that others missed time at work to transport them. 5% had to arrange for a babysitter, and 1% may have entered into the 4th month of pregnancy because of the imposed waiting period. The authors found that the cost of compliance did not differ by race, age, income level, or student status of the women. Although Lupfer and Silver tried to limit interviewer bias during the patient interviews, more than 200 of the sessions were conducted by counsellors employed at the clinics. This may have biased responses, since the counsellors had relationships with the patients who may have answered in ways that they believed the counsellors would approve of. However, as an early study that looked at the impact of a mandatory counselling and waiting period law immediately after implementation, this study provided excellent first-hand data on patient experience. But because the data was collected nearly 3 decades ago, a new survey would be valuable, since these kinds of laws are now widespread, and women and providers may have adjusted to the laws in ways that might mitigate some of their impact on access to abortion services. Examining the other side of service provision, Outhouse and Henshaw interviewed clinic administrators in 2 clinics in Ohio and Pennsylvania from August to December 1992 to assess how many mandatory counselling and waiting period laws affected them in their practice. At the time, Ohio law dictated that information about the methods and risks of the abortion procedure, the probable gestational age of the woman's pregnancy, the medical risks associated with a continued pregnancy, and other information had to be provided in person, by telephone or by mail, at least 24 hours prior to an abortion. Pennsylvania's mandatory counselling and waiting period law required that a physician verbally inform a woman of the nature of the abortion procedure, the risks involved in abortion and childbirth, and the probable gestational age of the pregnancy at least 24 hours before the procedure. The woman was also offered information about the availability of state-produced written materials describing the fetus and medical assistance for continuing the pregnancy, the father's liability for child support, and agencies that could provide alternatives to abortion. The law was interpreted to mean that this information must be given in person, hence requiring 2 trips to the clinic for an abortion. At the time of the data collection, the Pennsylvania law had been in effect for only 4 months. Although neither clinic had yet conducted a formal analysis of the effect of the law on their service provision or fiscal outcomes, providers did note a sudden scheduling nightmare for patients, a decrease in the number of appointments made, and an increase in required staff and staff time. Furthermore, the authors were told that costs associated with staffing, printing extra consent forms, purchasing the state-prepared brochures, and mailing the brochures to patients had become a financial burden for some clinics in these states. For example, the cost at one clinic in Ohio rose by 10%. The authors noted that the experiences of providers may change over time as they learn to adjust to the requirements of mandatory counselling and waiting period laws. The study was limited by the small number of providers surveyed and an inability to follow providers over time to see if they adjusted to the laws. Nevertheless, their data provide valuable, direct information on the immediate burden that such laws place on abortion providers. Infant and child health outcomes. 2 papers by Bittler and Zavodny used annual state-level data on indicators of child maltreatment. In the first paper, the authors analysed reports of child abuse and neglect between 1976 and 1996 to assess the possible correlation between mandatory counselling and waiting period laws and these outcomes. In the later paper, they expanded the outcomes to include the receipt of children's social services and the rate of child mortality attributed to possible abuse and murder. They also assessed the effect of abortion legalization in the early 1970s on these outcomes. The researchers found that both enforced and enjoined mandatory counselling and waiting period laws were associated with a 5 to 23% decline in child abuse reports in the year the law was either enforced or enjoined. Their results varied by outcome and by when the law was assigned to the outcome. For instance, coefficients changed from positive to negative when the laws were assigned to the year of conception rather than the year of receipt of social services or of death. In the second paper, the results were also inconsistent as associations vary with different measures of abuse. For example, the authors determined that enjoined mandatory counselling and waiting period laws were strongly associated with an increased number of abuse reports, but with a decreased number of substantiated victims. The latter were analysed only for the period 1990 to 1996. When they analysed relative changes in the outcomes using logarithms, their estimated effects were substantial. 32 to 63% declines in the number of substantiated victims. Enjoined laws were also associated with a 45% increase in the rate of murder of a child by a relative or unknown person, but were unrelated to murder by a parent. Bittler and Zavodny's results for mandatory counselling and waiting period laws strain credulity. First, the estimates fluctuate dramatically depending on the outcome and years. This is not surprising, given that the laws were not consistently enforced until the Supreme Court decided Planned Parenthood of Southeastern Pennsylvania versus Casey in 1992. And also because, according to the author's own assessment, few individuals in the sample were exposed to the laws. For instance, they report that only 0.1% of the sample was subject to an enforced mandatory counselling and waiting period law between 1979 and 1996, and only 0.3% was exposed between 1990 and 1996. The proportion of their sample exposed to an enjoined law was also never greater than 1%. Furthermore, effects as large as 30 to 60% probably indicate omitted variable bias, as does their finding that enjoined laws often had larger effects than laws that were enforced. Finally, the relationship between mandatory counselling and waiting periods and child abuse is purportedly attributed to an increase in unintended childbearing associated with these laws. But there is no evidence that such laws have had a statistically significant effect on birth rates, even in Mississippi, where the results appear to be most robust. Without this connection, there is no compelling explanation for how the laws could influence child abuse. Sen tested the hypothesis that state-level restrictions on abortion were linked to increases in children's rates of fatal injuries. She analysed 3 restrictive policies: mandatory counselling and waiting period statutes, Medicaid financing of abortion, and parental involvement laws. Her reasoning, similar to that of Bittler and Zabotny, was that abortion restrictions might disproportionately increase births of unwanted children, as well as births to young, single, and low-income women, which might in turn lead to adverse child outcomes. The author analysed state-level data on fatal injuries among children aged 0 to 4 for all 50 states for the period 1981 to 2002. She chose this age range because she argued that past analyses had suggested that children in this group are the most vulnerable to fatal injuries associated with abuse or neglect. 3 causes of injury-related deaths were considered: homicide, unintentional causes of any type, and unintentional causes other than motor vehicle crashes in which the child was a passenger. A count data model with state and year effects was used for estimation, and results for each cause were presented for white and black children. The author found that mandatory counselling and waiting period laws were associated with a 24% increase, though not statistically significant, in homicide deaths and a statistically significant 9% increase in unintentional fetal injuries among white children. Among black children, homicides were 30% higher in states with enforced laws. All other results were not statistically significant. Sen also conducted falsification tests in which she regressed fatal injury rates among adults aged 25 to 64 on indicators of abortion restrictions. Any association among adults would be considered spurious and would call into question similar associations with fatal child injury rates. Indeed, Sen found that such laws were correlated with higher rates of homicide among black and white adults and with a higher rate of unintentional fatal injuries among black adults. Yes.
Once again, my name is Reese Novak-Wilson, and I'm from Rogersville, Missouri. One study in our review measured the effect of mandatory counseling and waiting period laws on female suicide rates. Study examined suicide rates among women aged 25 to 64 in all states using a pooled time services analysis of data from 1981 to 1998. In a multivariate model, he included the proportion of a year in which a Medicaid funding restriction was in place, as well as controls for other potential confounders, such as women's labor force participation, the unemployment rate, average state income, proportion of the state's population living in rural areas, education education levels, and religious identification. In some cases, he included male suicide rates to control for unobservable variables that might affect female rates. In the most basic regression, Flick found that mandatory counseling and waiting periods were associated with 10% reductions in female suicide rates. These estimates were robust to the inclusion of state-specific linear trends, as well as to the male suicide rate. He noted that laws that restrict abortion access were more likely to be implemented in more politically conservative states, and thus may be correlated with unmeasured changes that cause suicide rates to fall. To purchase estimates of this potential omitted variable bias, he used an instrumental variables approach and found that such laws were associated with a 30% decrease in suicide rates. The author concluded that waiting periods induce a more reasoned approach to the abortion decision. Despite the apparent thoroughness of the regression analysis, Flick's finding lacked transparency and plausibility. First, if mandatory waiting periods are indeed associated with a 30% decline in suicide rates, then such large continuities should be apparent in the time series of suicide rates in the state that have enforced these laws. Flick provided no such figures or even simple difference of suicide rates in states with counseling and waiting period laws, and neighboring states without them. Second, it is unclear why Flick included suicide rates from 1981, when the first laws were not enforced until 1996. Nor did he analyze the association between suicide rates and mandatory counseling and waiting period laws in this earlier period, which accounts for over 60% of the sample. Such an analysis could have served as a check for spurious accusations. Third, Flick found that the mandatory counseling and waiting period laws were protective against suicide, but that Medicaid financing restrictions increased suicide rates. Yet he did not provide a convincing explanation for these seemingly contradictory results, given that both types of restrictions decrease women's access to abortion. Flick speculated that Medicaid restrictions reduced the number of abortions, but the resulting unwanted births among relatively poor women led to depression and suicide. In contrast, he suggested that mandatory counseling and waiting period laws may also reduce abortions and increase unwanted births, but that non-poor women may respond to unintended childbearing with greater acceptance of the child, and suffer less depression and be less likely than poor women to take their own lives. Flick further argued that if these laws have no effect on abortion rates, they may still reduce suicide rates by helping women become more comfortable with their decision to terminate their pregnancy, thus reducing post-abortion regret and depression. He provided little support for these various speculations. Finally, Flick included women aged 25 to 64 and excluded those aged 18 to 24. The latter age group has the highest abortion rate, while many of the older women that he included were beyond reproductive years. Attest to the effect of enjoying the mandatory counseling and waiting period laws would have helped to determine whether unmeasured confounding of variables were influencing the results. Early qualitative assessments of experience with mandatory counseling and waiting period laws found that abortion patients and providers were burdened in multiple ways by the legislation. Women who obtained an abortion described a negative physical and mental health consequences, such as physical discomfort and mental distress. Women also include increased burdens from having to visit clinics multiple times and having to travel out of states to a provider who is not affected by such laws. Interviews with providers suggested that many struggled to adjust to the laws immediately after implementation. These early findings make intuitive sense, as any change in this type of regulation will have some type of effect on providers and patients, particularly as the logistics of meeting the new requirements are being worked out. But it is important to note that these studies were conducted in a limited geographic area and include a relatively small number of women, providers. Despite a limited generalizability of these qualitative studies, they are valuable because they are the only ones to evaluate mandatory counseling and waiting period laws using such methods. The remaining research on mandatory counseling and waiting period laws fall into two groups: case studies that focused almost exclusively on Mississippi, and state year analyses that examine changes in reproductive outcomes, infant or child outcomes, or suicide across all or almost all states over time. The results from Mississippi were the most convincing. Overall, the state's mandatory counseling and waiting period statute, with its requirement that all counseling be done in person 24 hours prior to an induced termination, was associated with a decline in the abortion rate, a rise of abortions obtained out of state, and an increase in the proportion of second trimester abortions. These findings were consistent across 3 studies, each with a distinct research design. The other convincing aspect of the Mississippi studies was the nature of the data. For each study, researchers had collected information about abortions obtained by Missouri residents in that state, as well as in Tennessee and Alabama. This proved critical, as the number of women who left Mississippi for an abortion in a neighboring state were substantial. Finally, the outcomes analyzed were effective immediately by the law, and the statistical approaches were simple and transparent, which made the results easier to evaluate. Because Mississippi differs somewhat from other states demographically, economically, and politically, it is unclear whether the effect of an equally restrictive law in other states would be greater or less than in Mississippi. Unfortunately, few other states have collected the necessary data to allow analysis of the impact of mandatory counseling and waiting period laws. The broader analyses that include data from all available states found that counseling and waiting period laws have no impact on abortion rates or birth rates. Those laws are less demanding than that of Mississippi, and it is probably safe to conclude that if they affect the reproductive outcomes, the effect is not large. However, the possibility of unmeasured confounding variables and other limitations of the studies preclude ruling out small effects. A corollary finding that is mandatory counseling also has little effect on women's abortion decisions. Since states require that specific information to be provided to the woman before the waiting period, if the delay has no effect, then neither does the mandated counseling. Finally, the studies of impact on child abuse and mortality, not the women's suicide rates, are unconvincing because of anomalous findings and the lack of evidence of the law's increased unintended childbearing enough to account for the results. We conclude that the mandatory counseling and waiting period laws that require an additional in-person visit before the procedure likely increase both the personal and the financial costs of obtaining an abortion, thereby preventing some women from accessing abortion services. If neighboring states have similar laws, so that access to an abortion provider who does not require this form of waiting period requires extensive travel, then such laws are likely to lower abortion rates, delay women who are seeking abortions, and result in a higher proportion of second trimester abortions. Laws that allow mandatory counseling to be delivered over the internet or by mail or telephone impose lower costs on both patients and providers, and neither the waiting period requirement nor the counseling appears to have a large impact on reproductive outcomes. However, by definition, such statutes do cause some delay, and one study that addressed this issue found a 41% increase in the rate of second trimester abortions. While this may not be an accurate measure of the magnitude of the effect, it is likely that some abortions are delayed to the second trimester. Six studies evaluated changes in abortion rates and ratios following the implementation of mandatory counseling and waiting period laws. One study also assessed impact on birth rates. 4 studies analyzed changes in the timing of abortion, and 3 examined the impact of laws on changes in where abortions occurred. 4 out of the 6 studies found a statistically significant association between mandatory counseling and waiting period laws and abortion rates. 3 of these studies focused on Mississippi. The studies are presented chronologically. 2 studies, which are presented last, found no impact of these laws on reproductive health outcomes. Altus and Henslaw examined detailed abortion data from the Mississippi State Department of Health Division of Public Health Statistics to determine the effect of the state's 1992 mandatory counseling and waiting period law on abortion trends. The researchers had used state-collected information on residents who had abortions in Alabama and Tennessee to examine the effect of the law on women traveling out of state. The bordering state of Louisiana does not collect abortion data on out-of-state residents, and authors did not gather data from Arkansas. Typically, other mandatory counseling and waiting period laws, Mississippi's statute required that a woman be given information at least 24 hours prior to the abortion regarding the name of the physician who would perform the procedure, the medical risk associated with abortion, the probable gestational age of her pregnancy, and the medical risk of continuing her pregnancy. In addition, a woman was required to be informed about the medical assistance for the benefits available to her as she continued the pregnancy. To follow there's liability for child support, the availability of pregnancy prevention services, her right to review state-produced materials that listed services to assist a woman through pregnancy and childbirth, and a brochure that described fetal development. All of this information had to be delivered by the referring physician or the physician performing the abortion. In Mississippi, the law requires a woman to hear the information in person. Clinics have interpreted as face-to-face. This necessitates 2 in-person visits to the clinic. In a before and after analysis of state-level abortions, that researchers found that the actual number of abortions performed in Mississippi was 22% lower than expected based on previous years. They also found that the number of abortions provided to non-residents fell 30%, while the number of Mississippi residents who obtained an abortion in Tennessee or Alabama increased by 17%. Overall, the researchers concluded that among the women who would have abortions, the law prevented approximately 11% to 13% of them from attaining one. The law was also associated with women having abortions later in pregnancy. The proportion of Missouri women who had obtained an abortion after more than 12 weeks of gestation increased by 17% in the 5-month period after the law was enforced, compared with the 7-month period prior to enforcement. In addition, the decline in abortions was greater for women with less than 12 years education than for more educated women. This was the first study to use data on abortions to evaluate the impact of mandatory counseling and waiting period laws. A strength of the study is use of abortion data by state of residence. The data showed that not only women leave the state to obtain an abortion, but fewer women came into the state for an abortion. The major limitation of the study is the lack of a control group other than Mississippi in the months before the law took effect. Although the number of abortions fell sharply in the months right after the law's enforcement, abortions have fallen somewhat in the absence of the law. Thus, we don't doubt the waiting period requirement has a statistically significant effect on the number of abortions in Mississippi, but the exact size of the decline is uncertain because of trends in abortion that may have existed prior to the law. Joyce, Hinshaw, and Scatcherd extended the work of Altus and Hinshaw by analyzing the effect of Mississippi's mandatory counseling and waiting period stature on abortion rates and birth rates, as well as on the timing and location of abortions for the period 1989 and through 1994. They used Georgia and South Carolina as comparison states, since neither of the states enforced a mandatory waiting period during these years. This enabled the researchers to use a difference in methodology. The authors also estimated a regression in the model using monthly abortion rates in the three states over this period. The authors reported that the abortion rate in Mississippi dropped by 60% in the year following enforcement of the mandatory counseling and waiting period law. In the same period, the abortion rate fell by 5% in South Carolina and 3% in Georgia. Thus, they estimated that Mississippi's law was associated with a 12% to a 14% decline in the abortion rates among residents. The authors concluded that they likely overestimated the decline since they lacked data on Mississippi residents who obtained abortions in Louisiana. To adjust for this, they estimated the number of abortions that residents obtained in Louisiana based on the state's 1988 data. After adjustments, they concluded that Mississippi's mandatory counseling and waiting period law was associated with approximately a 10% decline in the resident abortion rate. The authors also found the number of abortions obtained out of state rose in absolute and relative terms, as did the number of abortions performed after 12 weeks of gestation. The authors researched no conclusion regarding the impact of law on birth rates because of lack of statistical power. This study underscores the strengths and limitations of individual state analysis. First, the author's ability to measure changes in where abortion occurred was critical. Without resident abortion rates, there would be no way to accurately assess the impact of a law on the data, even though it appears good. As comparisons with data obtained by the Guttmacher Institute independent survey of abortion providers indicate that Alabama, Tennessee, and Mississippi have relatively complete abortion reporting. Thus, the authors were able to assess the extent to which women left Mississippi to obtain abortions in these other two states, which turned out to be substantial. The proportion of abortions obtained in Mississippi residents outside the state increased by 42%. Another strength of the study is the selective use of comparison states. Georgia and South Carolina are demographically and politically similar to Mississippi. Indeed, both of these states went on to enforce mandatory counseling and waiting period laws. Finally, the authors presented the data in a transparent manner. They showed trends in abortion rates and in birth rates in Mississippi and the two comparison states, both before and after the law. The regression results simply confirmed statistically what was apparent from the time series plots. However, the authors did not adjust for serial correlation in the residuals and likely underestimated the standard errors of the regression coefficient that measured the impact of the law. In addition, in all case studies, the magnitude of the effect may be different on other states. Mississippi is a poor rural state that has one of the lowest numbers of abortion providers per capita in the country. Furthermore, Mississippi's law is stricter than most states, such that it is interpreted to mean that the pre-abortion counseling must be conducted in person. Other states that mandate counseling in a 24-hour delay permit information to be delivered over the phone, by mail, and over the internet. The authors argued that their results were unlikely to be generalizable to states that did not have an in-person requirement, which effectively requires at least 2 visits to the clinic. Despite these limitations, they both worked by both Alphas and Henshaw and Joyce. Henshaw and Thatcher underscores the need to interpret results cautiously from the studies that evaluate mandatory delay laws using abortions measured by state of occurrence. Joyce and Heistriner returned to Mississippi to evaluate in more detail the effect of the state's mandatory counseling and waiting period law on the timing of abortion. Again, the appeal of Mississippi as a case study is the strictness of the law, a 2-visit person requirement, and the quality of the resident abortion data. The study was unique because the authors created Within state compromise, a group of women who lived closer to abortion providers in Tennessee and about Alabama than to providers in Mississippi. They hypothesized that these women would have been more likely to gone to providers in Tennessee and Alabama in years prior to enforcement of the law, and thus would have been less affected than the woman whose nearest abortion provider was in Mississippi. Their results bore this out. They found that by the proportion of second trimester abortions rose by 45%, and the mean gestational age of abortion increased by 4 days among women whose closest provider was in state compared with women whose closest provider was out of state. These results were consistent with those of Althus and Henshaw and Joyce. Henshaw and Scatcherd, which should not be surprising, since all three studies focused on Mississippi. However, each study uses a different counterfactual or comparison group, which makes the consistency more compelling. Nevertheless, the three studies pertain to one state and one specific type of law, and thus their generalizability should be viewed with caution. Using data from the Centers for Disease Control and Prevention on Abortions by the state of occurrence, Bittler and Zavadny conducted a pooled time series analysis for 29 to 40 states for the period of 1974 to 1997. Not all 40 states reported abortions by gestational age each year. Their goal was to access how policies that restrict access to abortion services affect the timing of abortions and the abortion rate among women aged 15 to 44. One policy they analyzed was mandatory counseling and waiting period laws. They used regression analysis to control for demographic characteristics and state economic conditions. They also included proxies for the political climate, as well as the state and year-fixed effects. By 1997, 11 states had begun forcing mandatory counseling and waiting period statutes, but these state-year observations accounted for only 3% of the overall sample. In models without state-specific trend terms, these laws were associated with a 2.3 percentage point increase in the proportion of abortions occurring in the second trimester, with a 41% increase in the rate of second trimester abortions. Laws had no statistically significant effect on the overall abortion rate. A strength of the study is the analysis of both proportion and the rate of second trimester abortions. It is possible for the proportion to rise, but the rate to remain unchanged, or even fall, following implementation of a mandatory counseling and waiting period law, if the overall abortion rate declines because of a decrease in first trimester abortions. The results regarding an association between the timing of abortion and the state's law appear to be in approximate agreement with those of Athalas and Henshaw, and Joyce, Henshaw, and Scatcherd. However, Mississippi's law was associated with a significant decrease in abortion rates, whereas Bittler and Zavadny found no such association. This is an important difference. Since the decline in the abortion rate in Mississippi associated with the law would have been much larger if the studies by Althus and Henshaw and by Joyce, Henshaw and Scatcherd had measured abortion by state of occurrence. Many residents of Mississippi left the state for an abortion in the year immediately after the law was implemented, and fewer non-residents came into the state to obtain an abortion. In other words, by analyzing abortions by state of occurrence, Bittler and Zavadny's study was biased toward finding a decline in the abortion rate. Since by 1997, only Louisiana, Mississippi, Pennsylvania, and Utah required 2 in-person visits. This study suggests that the mandatory counseling and waiting period laws that do not require 2 clinic visits have little effect on abortion rates, but may cause delay in terminating a pregnancy. However, if the increase in the second trimester abortion rate was greater than could plausibly be caused by counseling and waiting on period. Meyer et al. Used a full time series design and data from all 50 states from the period 1982 to 1992 to estimate the effect on of a waiting period law and an informed consent statute, which should not necessarily mandate a waiting period on the abortion rates of all women aged 15 to 44. These laws were among 23 policies related to abortion that were included simultaneously in the analysis. Results indicated that neither the waiting period nor the informed consent statute had an impact on the abortion rate. This study is unique in that the researchers did not account for states' fixed effects, but instead included the previous year's abortion rates to control hard-to-measure determinants of abortion.
Hi, my name is Shemin Schwa, and I am a pro-choice married Catholic woman here in Missouri. And I am going to read a little bit from the Articles of Faith. And I'm going to start with an excerpt from Matt Becker, who was a Catholic physician. It was none of his business, that was all. His patients could follow the magisterium or not follow the magisterium. They could go make their own confessions if their consciences were troubling them. He was not going to lecture them about artificial contraception. He was not going to debate artificial contraception on a public stage, and he was certainly not going to drive to the capital city of his home state and demand that his church's directives on artificial contraception be incorporated into the statute books. The statute books were for everybody, Catholics and non-Catholics alike. And you didn't spend 2 hours negotiating the highways to Jeff City or lose your Thursday evening to the Creveport Township Republican Organization unless everybody was involved, unless the men in charge of the statute books were tampering with an idea as basic as the protection of human life. And here, finally, was something Matt Becker found written in the human heart. Safeguarding unborn life was not Catholic business in any way that Becker understood the special comforts and rigors of Catholicism. It was not denominational. It was not religious at all, except in the sweeping sense that all of us are God's creations and made, born or unborn, in his image. Matt Becker happened to believe that, but he was not going to get up and argue about it before an audience. Science was what he would argue, and science was always how he began. I would like to present some medical evidence, Becker would say, and the house lights would darken, and he would proceed to the first abortion slide. Making decisions based on principle. The Jesuits had taught him how to act, but not what to say. That was Becker's way of thinking about it. And if debate audiences heard him, and Jefferson City legislatures heard him, it was because his medical evidence was sensible. It was rational. It was universal. It was right. It wasn't his fault that Catholics happened to see it first. His picture ran in the National Catholic Register. Becker, white-jacketed, looking grim, with a stethoscope around his neck, and behind him, an anatomical drawing of an infant in the womb. More letters came in the mail. From Yardley, Pennsylvania. We want to encourage you in your fight to prevent liberalization of abortion law in Missouri. We too are fighting it in Pennsylvania. From Flushing, New York. Enclosed is my check for $5 to aid you in this fight. I'm a New Yorker who has been horrified by the law our state assembly has passed. From Klamath Falls, Oregon. We are very much concerned here with the new change made in our state abortion law, where an unborn child can be aborted up to 5 months and for almost any reason, right to life, an organization protecting the right to life of the unborn, as well as other people, is fighting this type of legislation. He wasn't famous, not really. By 1971, there were Matt Beckers all over the United States, each with the lecture notes and the photograph collection, traveling from state house to debate stage and back again. Big city newspaper writers knew who to call when they needed a ready voice for no on liberalization. Some of the no leaders were physicians. Some were lawyers, some were nurses, or homemakers, or businessmen. Edward Bolton, the head of the rapidly growing New York Right to Life Committee, was a building contractor, and some of them, too few in Becker's view, and too meek when they did make a showing, were clerics. In St. Louis, Cardinal John Carberry read for a news conference a joint pastoral letter co-signed by all 7 Missouri bishops and intended for Sunday dissemination in every Catholic parish. A society which legalizes the killing of the unborn is not only violating God's law, but is opening the door to more hideous abuses of life, the letter read. If the pastoral letter was meant as a solemn declaration to put the matter to rest, it failed. The pace was quickening, and Backer knew it. In March 1971, a repeal bill was introduced in Missouri. A no categories, no committees, abortion through the second trimester bill, like the one that had passed in New York. A citizens committee had drafted its own version of a repeal bill and pleaded publicly for a legislator to carry it. The representative they found, DeVern Calloway, was a 55-year-old St. Louis Democrat and one of the only black women in the Missouri legislature. Social hypocrisy, DeVern Calloway wrote in a letter to the St. Louis Democrat describing the century-old abortion law she was now proposing to dismantle. Despite these laws, crimes continue to rise and women increasingly are having abortions. Backer packed up his notes and got back on the highway to the Capitol. At least now he need waste no more breath with his explanations that model penal code-based abortion bills were an open door to an abortion on demand. DeVern Calloway's bill, as Becker read the wording in the folded state handout, was abortion on demand. They might as well have written it into the legislature language. Be it enacted by the General Assembly of the State of Missouri, abortion on demand. No abortion shall be performed in this state unless 1. Such abortion is performed by a licensed physician, and 2. Such abortion is performed in a licensed hospital. That was the critical sentence in HB 650, relegating abortion to the status of a gallbladder operation. And on the evening of the bill's first public hearing, the crowd at the State House was so large that the meeting was moved from the modestly sized legislative hearing room into the full House of Representatives chamber. Calloway and her co-sponsors had brought in a lineup of witnesses to defend the bill, and as the witnesses took their turns one by one at the microphone, a Missouri Catholic Conference employee listened and made notes. She indicated that she was brought up morally opposed to abortion, but does not think that one group has the right to legislate for all. He claimed that the poor do not want children, but they have neither the funds nor the education to keep from having them. She claimed that historically there were only practical reasons why abortion statutes were written, i.e. surgical conditions were so poorly developed at one time as to make abortion extremely hazardous. Thus laws were written to prohibit them. These were familiar arguments already for anyone who had spent the last 3 years culling useful material from the debates around the country. They were beginning to be old arguments. In fact, it worried Backer to hear them again in the halls of his own state legislature. It was unimaginable to him that the curious state of Missouri might accept into its statute books an idea as radical as abortion on demand. But he knew that if you hammer it anything long enough, it begins to show cracks. Perhaps the legislatures would hear them all out, the witnesses for and the witnesses against, and then retreat to their offices to settle on something that looked to them like compromise, some permissible killing of innocent human life. And Backer knew this as well. The legislative chamber of the Capitol building, at least in theory, the democratic center of every American state, was no longer the only place where the conflict might finally be won or lost. In the first months of winter, 5 months before the introduction of the Calloway repeal bill, the Attorney General for the state of Missouri had called Backer's office to enlist the doctor's defense against an entirely different sort of attack, a lawsuit in St. Louis County Circuit Court, contending that the abortion law of the state of Missouri violated the individual protections guaranteed by the United States Constitution. The suit was called Samuel U. Rogers, M.D. versus John C. Danforth, Attorney General of the state of Missouri. Its full formal name was longer than that: 4 physicians, 3 clergymen, and 3 women of childbearing age. In the language of Rogers versus Danforth, we're bringing a complaint against Danforth and St. Louis County prosecuting attorney Gene McNary. There was no personal reference in the lawsuit to either Danforth or McNary. They were named solely as individuals charged with enforcing state law, just as Henry Wade, the district attorney for the county of Dallas, had been named a defendant in a similar suit in Texas. And if the courts approved it, Danforth had explained to Becker a separate third party might be permitted to enter such a lawsuit too, as a guardian ad litem. The court appointed adult representative for an infant whose own interests might be at issue in a legal dispute. They needed both Backer's testimony, Danforth said, and the use of his name. Would he enter Rogers versus Danforth on behalf of a class of infants? children presently in existence but unborn. As the legal papers would phrase it, who could understand by the judicial system to be arguing through Becker that they were human persons who possessed a constitutional right to life? Certainly, Becker said, of course he would. Thus, M.H. Becker, Jr., M.D., temporary legal guardian for a fictitious American fetus whose official name in the Missouri court papers was Intervenor Defendant Infant Doe, joined in early 1971 the great funnel of abortion litigation aimed at the United States Supreme Court. Exhibit A, 1970. One evening, Judy and Art Whitcomb, who had wondered whether police listened in on the conversations that took place over the back porch telephone, decided to look around for wiretaps. They felt beneath the telephone and looked under the desk and studied the interior baseboards and corners of the screened porch. And then they found flashlights and went outside and shone their lights up and down the telephone wires, wondering whether a tap was something a person could see while squinting up from the backyard lawn. They never found anything, but they knew they were being observed. At occasional intervals, an unmarked car cruised slowly up and down their street, its windows rolled shut, its occupant making no effort to identify himself. There was one 2-day scare that frightened Judy terribly at first. A message passed to her one day at the hospital. Urgent, call your mother-in-law. And Judy's mother-in-law whispered into the telephone, the sheriff's office called. They have something they want to serve you. And Judy frantically calling Gwen Harvey, and Gwen Harvey calling the county coroner, because the county coroner had access to arrest warrants. And the county coroner telling Gwen he would find out what he could, but that in the meantime, the Whitcombs must get out of the country at once. Judy and Art secured their son at a friend's house and retreated across the county line to spend the night at Gwen's, trying to figure out, Judy recalls, who was the son of a bitch that turned us in. Finally, the Whitcombs went home, seeing that there was no point lurking beyond the county boundaries, and waited for the call from the sheriff's office. When the call came, Art answered the telephone, and as he handed the receiver to Judy, she was startled to see that he was smiling. It's okay, Art said. The guy wants your services. His girlfriend's daughter is pregnant. The clergy service accommodated the young woman, collectively violating the Missouri Criminal Code one more time. Collectively, according to the defining paragraph of section 559.100, risking up to 5 years imprisonment for offering advice with intent to produce or promote a miscarriage or abortion. The word advises appeared twice in the manslaughter abortion statute, alongside gives, sells, administers, and procures. And a separate state law listed items that might be seized by police upon issuance of a warrant. Any of the following articles kept for the purposes of being sold, given away, or otherwise distributed or circulated contrary to law, vis-a-vis pills, powders, medicines, drugs or nostrums, or instruments or other articles or devices for producing or procuring abortion or miscarriage or other indecent or immoral use, or any letters, handbills, cards, circulars, books, pamphlets, advertisements, or notices of any kind describing or purporting to describe any of such articles or giving information, directly or indirectly, when, where, how, or of whom any of such things can be obtained. The wording of the statutes had not been changed to account for the fact that abortion was now legal under some circumstances in certain states outside Missouri. Inside Missouri, it was still a felony, and although nothing in Missouri law prohibited women from crossing the border to engage in an act that was lawful elsewhere, handing over the telephone number of an out-of-state abortion doctor could surely qualify as advising with intent to promote. By mid-1970, 300 women per month were coming through the clergy service referral system, and even after New York opened up, the counselors continued to make occasional referrals to efficient illegal abortionists who were closer or cheaper than the physicians so busily opening up shop in Manhattan. Women drove up the highway to the Corpsman in Chicago, or flew down to Mexico City with Dr. P's telephone number penciled discreetly, as per clergy service instruction, amid the other numbers in their address books. Some of the women have been asked at the border when coming back if they have been to Mexico to see Dr. P, Gwen Harvey warned the clergy service counselors in a December 1970 memo. Needless to say, the girls didn't know who he was. Lapel ribbons for the Mexico abortion patients. That was one of the details Missouri clergy service counselors excuse me, were expected to remember that every woman traveling to Mexico for an illegal abortion was to pin on a small white ribbon so the driver could pick her out at the Mexico City airport. Also, the New York clinics had to be paid by traveler's check, money order, or cashier's check. No cash, please. Also, the California doctors would not accept personal checks. Please ignore the rumor that the Los Angeles doctor took MasterCharge. Also, be sure to remind the women how to handle an airplane ticket. Ask for a boarding pass. Write down the number of the departure gate. Sometimes the women were casual and competent at matters like these, but more often it seemed to Judy that they were not. They were frightened and young and had never been on an airplane before, and they were leaving the state alone because it cost too much to have somebody come along to hold their hands. In the college town of Columbia, where the clergy service counselors worked out of the University of Missouri Ecumenical Center, the local coordinator had prepared herself for students and was startled to see all the others who came in too. The professional women in tailored clothes, and the girls from the farming country in cars that bumped awkwardly onto campus, with unsmiling relatives squeezed into the back seats. I have an image of a big car that has rust on it, and the car is full, recalls the coordinator, Georgie Gatch. I remember one where there literally was an uncle and a grandfather and a grandmother. I mean, the whole family came up, and they did not have a lot of the defenses a more educated person does. They would say she was pregnant, or she was in the family way. They usually pretty much knew the timing, and that there was a problem, and we want to get rid of the pregnancy. There was very little hesitancy about an abortion. They knew what they wanted to do. How to do it was very difficult. There was a humorless little counselor's joke, Georgie Gatch recalls. Give them the information and have them swallow the piece of paper. As a layperson, Gatch probably had no claim even to the uncertain protection of priest-penitent confidentiality when she volunteered illegal information in a clergy service session. But it was not the threat of arrest that troubled her most. The entire scenario was wrong, Gatch thought, especially when the farm family sat before her. These were girls for whom the drive to Columbia was an excursion to the big city. And here was a stranger on a college campus, handing them a telephone number for Chicago, or New York, or a place where people answered the telephone in Spanish. Once a month, Judy Whitcomb would buy an airline ticket for herself and board Flight 468, the first TWA jet of the day from St. Louis to LaGuardia Airport in New York, to link up with the morning's collection of abortion-bound women, walking the beat. As Judy saw it, making sure the connections were working and the clinics were managing their pickups correctly. And even as Judy talked to the uneasy women at the boarding gates, she knew that at least these women were waiting for airplanes, that they were not sitting alone in a Greyhound station in the midst of an all-night bus trip. That was what the clergy council women did when they could not afford the airplane fare. They climbed aboard interstate buses, or they catched car rides, or they scrabbled together gasoline money and drove west, or northwest, or south toward Mexico. 15 hours at a stretch if they had to, as long as it took to reach an abortionist the clergy service ministers had promised them was reliable and safe. That the routes were now marked, that they were no longer so secret, that some of them led to real clinics with physicians' names on the front doors, and expensive medical equipment inside. This was a kind of progress, as Judy saw it, and the newsletters from the National Association for Repeal of Abortion Laws were beginning to fill column after column with roundups of promising state house action around the country. Arizona's bill lifting all restrictions against abortion, performed by a licensed physician won House approval 32-37, cleared the Senate Judiciary Committee, but was bottled up in the Senate Rules Committee. One NARAL summary reported during the summer of 1970. An Ali-type reform law in Kansas, enacted more than a year ago, went into effect July 1st. Pennsylvania has a repeal bill filled. Representative John Galbraith of Ohio has filed a beautiful repealer that simply strikes out all reference to abortion from the criminal code. But when NARAL grouped its brisk roundups under subheadings, near repeal laws, and new Ali-type laws, and legislative defeats. The defeats column was 3 times the length of the others. Among the modest number of states that had succeeded in some modification of their abortion laws, only New York and California were opening their doors to significant numbers of out-of-state women. Missouri showed no sign of wavering at all, and forward-thinking legislation was a form of government already facing intense lobbying from right-to-life groups demanding that the state's new abortion law be repealed at once. Some ground had been gained since the era of medical articles with titles like "Foreign Bodies Lost in the Pelvis During Attempted Abortion." But from Judy's watch, the gain sometimes appeared modest indeed. Every time she came home on one of those TWA flights from New York, she spent some portion of the flight in the back of the plane, pointing out for the stewardesses the seating location of the passengers who were recovering from abortions. "Do you know what to do if one of them starts to hemorrhage?" Judy would ask, to the stewardess's alarm. Then Judy would balance herself back there beside the metal cupboards full of Coca-Cola and miniature liquor bottles and show them, lay the woman on her back, pack clean towels in to staunch the bleeding, press both palms against the pelvis to massage the uterus from above. As far as Judy knew, there were no actual calls for this form of first aid on any of the New York-St. Louis flights. But the point was in the lesson itself, altering the stewardesses, making them more solicitous of the pale young women who were flying over the eastern half of the United States just to return home from the doctor. Lobbying, political organizing, the redrafting of criminal codes, this was fine democratic work for a person who believed that 19th century state abortion laws no longer made any sense. But it was not enough. The city of St. Louis was still a place in which a man from the sheriff's office had to seek abortion help from volunteers who were breaking the law to oblige him. From Judy's perspective, all the vigorous state house effort had, in fact, produced only 2 good states, New York and California. And beyond that, a mess of state-by-state fine print that required a 50-item checklist just to remember which states were saying yes for rape, but no for mental health, and which were saying yes for mental health and forcible rape, but no for statutory rape, and which demanded 1 consultant, or 2 consultants, or a 3-member therapeutic abortion board. Judy was a nurse, not a lawyer or a lobbyist, but the checklist itself was enough to convince almost anybody that the campaign to change the country's abortion statutes was going to have to be run by separate assault teams, one to work the legislatures, one to commit civil disobedience, and one. This was how the civil rights activists appeared to have managed their successes a generation earlier, to challenge the statutes in court. In Missouri, the lawsuit was filed in May 1970 in United States District Court, and again in October 1970 in the Circuit Court of St. Louis County. Gwendolyn Harvey, identified in the legal papers as Vice President of the Clergy Consultation Services of Missouri and a married woman of childbearing age, was named as one of the 14 plaintiffs. Plaintiffs Harvey, Halberstadt, and Steinbeck are disturbed and distressed over the possibility of increasing their family size at an unplanned rate, read the opening plaintiff's brief in Rogers v. Danforth. They are keenly aware of the frequency of contraceptive failure and the inability to obtain abortion in the state of Missouri. Plaintiffs Harvey, Halberstadt, and Steinbeck have an inalienable right to decide for themselves whether or not to bear children, and this decision is one in which the state has no legitimate interest. There are many arguments in the plaintiff's brief and multiple affidavits, lengthy legal footnotes, and references to the 1st, 4th, 5th, 8th, 9th, and 14th Amendments to the U.S. Constitution. It was a long brief, 120 pages, and by the time it was filed, so much abortion litigation was already underway that new cases like Rogers were taking on a cut-and-paste quality. One of these arguments, one of those, 2 of those. But there resonated in this one small passage of Rogers v. Danforth a particular urgency for Judy Whitcomb, who was, during those opening months of Missouri litigation, a married woman of childbearing age who made regular, careful use of a contraceptive diaphragm. The diaphragm had failed. She was pregnant. In 1970, the business of the St. Louis County courts was conducted inside a severe-looking, six-story brick and concrete buildings that appeared to spread in many directions at once through the commercial center of Clayton, which is one of the suburbs abutting the boundaries of the city of St. Louis. The court's complex was less than a year old at this time, and each floor overhung the slightly smaller floor below it, a design that was probably meant to look modern, but instead gave the building a mass at once hulking and unbalanced, as though the entire structure had been lowered up from the lobby to a small bank of elevators, and up this courthouse escalator one morning in early October, a 29-year-old attorney named Frank Sussman carried the opening Rogers versus Danforth papers toward the fifth-floor reception counter of the clerk of the city court of the circuit court. Sussman was a trim young man, taller than average, with a mustache and wire glasses, and thick wavy hair that was somehow going to make him look even younger and more earnest when the newspapers began running photographs of his serious face. He was married, not happily. The marriage was about to end in divorce, to a woman he had met while an undergraduate at Brandeis. He had an infant son. During the early years of his marriage, Sussman had served for a while as an Army Reserves drill sergeant, teaching bayonet and hand-to-hand combat. And when he happened to mention this to people afterward, he was amused to hear them say that they found it either very difficult or very easy to imagine. He had a way of addressing people abruptly, as though he was still snapping off orders to nervous recruits. But amid the more experienced lawyers at his father's law firm, Sussman still spent most of his working hours as the low-man junior apprentice, taking busy work assignments to earn his place. He did divorces, corporate work, research on cases he was too much the novice to argue himself. The firm was in downtown St. Louis, and when Sussman had to pull from casebooks, he walked over to the Civil Court's building library, where the ceilings were 30 feet high and the long tables lit from the ends by low glass-shaded lamps. All the code books were here, on the shelves of the library, the criminal statutes and the taxation, the life of citizens of the American state. Here, too, were the reported opinions of every appellate court in the country, and in those volumes, the hardbound, somber-colored collections, with names as plain as monograms, U.S. Fed, Rep. Within those pages, a person might find the most exhilarating commotion of conflict and drama and clashing ideas. That was supposed to be the purpose of legal argument, the resolution of conflict in courts of law, and recorded amid the small conflicts were the written proceedings of the great ones. What are the protections of the United States Constitution? What is the relationship between legislatures and the courts? How far may a state go in controlling its citizens' behavior? What is the meaning of liberty, of due process, of equal protection under the law? Frank Sussman, 4 years out of Washington University Law School and 8 months shy of his 30th birthday, was delivering to the St. Louis County Circuit Court on October 1970, a stapled set of typewritten pages on which every one of these questions, implicitly or explicitly, had been addressed. The formal name for the papers was Petition for Declaratory Judgment and Injunction Relief, and that was how it was written, in capital letters, with Frank Sussman's name right below that, also in capitals. There were 3 other lawyers' names on the cover sheet with Sussman's, but his was the first. In oral argument and the newspaper clippings, it was going to be Frank Sussman's case, and his Western Missouri co-counsel, a more seasoned Kansas City lawyer named Charlotte Thayer, had concluded when she met Sussman that this was a young man who was not much interested in splitting either the work or the public credit. He didn't take to suggestions kindly, Thayer recalls. He obviously was out to make his reputation on this. For more than a year before the filing of the first Missouri abortion suit, Frank Sussman had been volunteering during some of his off hours as legal advisor, a title that sounded somewhat more official than the work itself proved to warrant, to the Clergy Consultation Service of Missouri. Sussman had met Gwen Harvey and Judy Whitcomb as they were planning the clergy service, and when he examined for them the wording of the state abortion statute, it looked to Sussman as though for legal purposes the women and all their pastoral co-conspirators were essentially flying blind. If we got caught, we were going to worry about it then, Sussman recalls. I'm convinced that we did not have a legal defense. There was something darkly appealing about this for a lawyer just starting out. Sussman had never before been prompted to think one way or the other about abortion, but the statute seemed to him so barbaric and stupid, forcing women to be pregnant when she didn't want to be, that he liked the idea of helping women set out to defy it. His parents, his mother had died when he was a teenager, had been political liberals, Jewish, only remotely religious. His father had joined in the preparation of Shelley versus Kramer, a famous 1948 U.S. Supreme Court case that struck down and unenforceable in state courts the written covenants meant to ensure that only white people could buy homes in certain neighborhoods. Frank Sussman had studied that Supreme Court ruling in his own constitutional law text, and like most law students, he had learned case by case and cause by cause the potential power of the planned and politically focused lawsuit. A lawsuit can function as a counterweight in a democratic society. Under the right circumstances, a lawsuit can work as a written reminder that what the voting majority and its elected politicians wanted is not necessarily right or just. A properly argued lawsuit could kill an entire state statute if a judge could be convinced that the statute was unconstitutional, that it denied to individual citizens some basic and profoundly important right that was written into the U.S. Constitution.
Will my fellow Missourian here for a question?
Yes.
Maybe just Thank you. My name is Sue Gibson. I am privileged to be here this evening for the Women's Filibuster. I am grateful to Margaret Sanger, Susan B. Anthony, and Emma Goldman, among many other women who came before me, and because of whom I have more rights today than I would have otherwise. As the Senate Republicans caucus at this hour to see if they have enough votes to question women's decisions about their own reproductive health care, we continue our filibuster. Because the Constitution was composed in 1787 and amended only occasionally during the 2 centuries that followed, many generations of contentious legal minds had been put to work trying to deduce exactly what the language of the document itself might mean, how the words as written might be applied to more modern problems, and also what ideas might be understood to be implicit in these words. And as Frank Sussman grew increasingly interested in his work with the clergy service, attending regional conferences and studying legal news from around the country, he learned that attorneys in more than a dozen other states were trying to find in the language of the Constitution a right to legal abortion, a right important enough to make judges strike down abortion statutes, no matter what state legislators thought about the merits of the laws. In New York, in the midst of the heated State House debate on the proposed new abortion statute, 4 separate teams of lawyers had brought lawsuits in federal court to attack the existing law as unconstitutional. In Georgia, where the legislature had voted in a limited categories model penal code law, the local ACLU director had tapped an Atlanta lawyer who was herself on pregnancy leave, preparing for the birth of her first child, to lead a federal court challenge, arguing that even the revised law was unconstitutional. In Wisconsin, 2 lawyers were using a constitutional challenge to defend a Milwaukee doctor who had been arrested for performing an illegal abortion. In South Dakota, a physician was challenging on constitutional grounds his arrest for performing an illegal abortion. And in Austin, where University of Texas graduate students at the local alternative newspaper had helped organize a clandestine abortion referral network, 2 attorneys, even younger than Sussman, had volunteered to prepare a constitutional case against the Texas abortion statute. As a national effort, this experimental new litigation was haphazard at first, with no central coordination more formal than long-distance telephone calls and back-and-forth mailings of clippings and sample legal complaints. The American Civil Liberties Union had taken its strong position on abortion law 2 years earlier. After more than a decade of internal argument, the National ACLU Board had finally approved in late 1967 a resolution proclaiming women's right to have a termination of pregnancy prior to the viability of the fetus. And when Sussman began his research in early 1970, he was directed across the state to Charlotte Thayer's Kansas City law office. Thayer was 15 years Sussman's senior, and had co-founded the ACLU's Western Missouri chapter. But she had no personal experience with abortion either. She had been asked some months back to host at her home a retired judge and ACLU board member who wanted to talk about the principle of a right to an abortion. And 25 years later, Thayer would still remember the way the women in her living room had sat silently after the judge's talk, afraid to look at each other or say anything aloud. Then one woman had put her hands together slowly, beginning to clap. And the second woman had joined her, and then all the women in the room were clapping so vigorously that it seemed to Thayer that relief had washed over the room, that the judge had said things all of them believed without even realizing they believed them. After that, Thayer had studied the background papers and commenced some public speaking of her own. The abortion decision is properly made by a woman and her doctor. Thayer would say, the abortion decision is a matter of personal privacy. The abortion decision is not the business of the state. Frank Sussman knew this argument reasonably well by 1970, and he happened to agree with it. But by itself, any argument could be dazzling in its eloquence and useless before a court of law. Judges were supposed to defer to the wisdom of legislators, unless the Constitution dictated otherwise. That was central to the constitutional system, to ensure, at least in theory, that judges kept to themselves their private opinions of laws written and adopted by the people's elected representatives. A judge could be personally appalled by the Missouri abortion statutes, could think it ridiculous that women should be risking post-abortion hemorrhage on the TWA flight from New York, and still declare that he had no authority to second-guess the legislators who were keeping that statute on the books. The authority, if it existed at all, was going to have to come from the Constitution, from those 18th and 19th century words and the century's subsequent interpretations of them. So Frank Sussman, like Margie Pitt Haynes in Atlanta, and Sarah Weddington, and Linda Coffey in Austin and Dallas, Texas, and a score of attorneys in separate law offices across the United States, set about constructing a brief to help a judge find that authority. He began, as lawyers do, with the work that had gone before him. Had any court in the nation explicitly decided that language in the Constitution could be read to promise a woman the right to a legal abortion? The courts of California gave Sussman his first answer. The case was called People versus Bellis, indicating by its title that someone had been accused of a crime and was fighting the people, the state of California. The facts in the Bellis case were laid out at the beginning of the opinion. Leon Philip Bellis, a Los Angeles obstetrician who had occasionally held forth on television and in newspaper letters to the editor, with his views that criminal abortion laws were too restrictive, had been telephoned in his office in 1966 by a distraught young couple who had seen Bellis on television. The young man and woman were unmarried. She was pregnant, and when Bellis told them there was nothing he could do for them, they told him they were desperate and would go for a risky Tijuana abortion if he refused to help. Bellis finally examined the young woman in his office, and when he declined either to perform an abortion or to give them an abortionist's name, they pleaded with him again, insisting, in the words of the ruling, that the young woman would have her abortion one way or the other. Finally, Bellis gave them a telephone number for an abortionist, a physician licensed in Mexico but unlicensed in California, where the physician had recently taken up residence and begun what Bellis had testified appeared to be a competent and relatively safe practice in illegal abortion. The couple made their arrangements and went to the doctor's makeshift apartment office. And while the young woman was recovering from her abortion, police raided the apartment. The abortionist was arrested, Bellis' name was found in a notebook, and after the abortionist pleaded guilty, Bellis was convicted by a jury of violating the state abortion law, the then applicable law, which defined as felonies both abortions and conspiracy to commit abortion. He was fined $5,000, placed on probation for 2 years, and stripped of his medical license. From these unlikely circumstances, a physician convicted for passing along a telephone number had emerged a statewide legal battle that climaxed in 1969 in the California Supreme Court. Procedurally, it was a complicated case, because by the time People versus Bellis went up on appeal, the California legislature had already revised the state law under which Bellis was convicted. By 1969, the model penal code language was in place in California and already being interpreted loosely enough to attract abortion patients from other states. But Bellis had links to the Committee for Therapeutic Abortion, the first California professionals organization to agitate for abortion law change. And as his conviction was appealed, a powerful lineup of legal and medical talent pitched in for a defense, intended not only to exonerate Bellis by finding the old California law unconstitutional, but also to argue that the new model penal code-based reform law had proved an inadequate remedy. One brief alone, a friend of the court argument prepared for the California Supreme Court, was signed by 178 medical school deans, including department chairs and the heads of every medical school in the state. A second brief was signed by 4 law school professors and more than a dozen other attorneys, including the president of the California State Bar. There were opposing briefs, to be sure: the right and duty of the state to protect fetal life, began one friend of the court brief, joined by a long list of clerics and physicians. And by the time the Bellis case reached the California Supreme Court in 1969, it had escalated into a full-scale duel over the legal and philosophical merits of restricting abortion in any way under the language of a state criminal code. Because the California Supreme Court of the 1960s was regarded by many legal observers as the most influential state Supreme Court in the nation, its rulings frequently looked to as examples of how other courts might proceed on a given issue. The outcome of the Bellis appeal was destined to resonate a long way beyond the boundaries of California. And when the Supreme Court ruled in favor of Bellis by a 4-3 vote, the state justices reversed his convictions. The writing of the opinion was assigned to a liberal justice named Donald Peters, who happened to have among his legal clerks that year a 32-year-old woman with very strong ideas about abortions and women's rights. Here was detail Frank Sussman could never have learned from the printed language there in a law library in St. Louis, but it left a deep enough imprint on the shaping of the law that 20 years later, from her Superior Court judgeship in Los Angeles, that one-time law clerk could say without hesitation, in response to an inquiry, "I don't need you to refresh my memory. It was the most important thing I ever did." Her name was Abby Sovin, and she was a Brooklyn native who had graduated near the top of her University of Southern California Law School class and gone on to this prestigious clerkship with the state Supreme Court. She had watched Sabella's case with extremely keen interest. The women on the court staff that year had all paid close attention to the appeal. And when the opinion was assigned to her justice, who was known for delegating to her clerks a great deal of the actual writing, Sovin asked outright for the assignment. She had never undergone an abortion herself, but she had a vivid memory of having asked her physician what would happen if she were ever to want one. The physician had told her she would have to go to Mexico, and even then, in the late 1950s, Sovin thought this outrageous. Some years later, she had lent her Southern California apartment to a friend who had arranged to have an illegal abortion inside. And Sovin remembered, too, the disquieting hours of waiting outside the apartment for the abortionist to finish his work. "I remember being very upset that things should be done that way," she recalls. "It struck me as being degrading and risky. I don't think I really thought it through, that there ought to be a right." Now, with the Bellis opinion assigned to her, Abby Sovin could think through the question of rights. When she examined the facts of the case, it was obvious at once that the statute they were considering was no longer valid. But Sovin dismissed any worries about that. There was a larger question at stake, and if the opinion was worded right, she could have a shot at answering it. "This is the opportunity,"